And that's something that we hope to do, right? Where we extend the envelope of human performance beyond just restoration of hand function.
Well, hello, everyone. Welcome back to the We're Not Stumped podcast. I'm your host, Mike Bolland, and today we're talking about the future of prosthetics. And this is not just replacing a limb, but restoring natural movement and even a sense of touch. My guest today is Dr. Chris Duncan, the new Chief Medical Officer at BIOS, a company leading the way in neural interface technology. His work is all about connecting prosthetics directly to the nervous system, bringing real function and real feeling back to people with limb loss. Chris, I am so excited about this podcast. Thank you so much for taking the time out of your busy day to be on the podcast.
Likewise, it's a pleasure to be here.
Well, I was going to say, I'm really looking forward to learning more, but the first thing we do on the podcast is a segment I call In Your Own Words, so people can learn a little bit more about you, the person behind all these great things. So I'd love to learn more about you, Chris.
So I am a physician in physical medicine and rehabilitation, which is a specialty dedicated to improving the lives and functions of people who have had complex medical diseases or traumas that have irrevocably changed their lives. So physicians like myself have been trained to help people after stroke or after spinal cord injury to be able to regain the ability to walk, talk, and think like normal. In addition to that, we are the specialty that looks after those that have acquired or have congenital deficiencies of limb loss. And it is a highly rewarding field because we're able to kind of restore the performance envelope of a human being to what they think is normal. So I started my training at Virginia Commonwealth University for medical school. And then for residency, I went on to the University of Utah, where I gained broad exposure to a lot of outdoor athletes that have amazing stories about rock climbing and parachuting and snowboarding and all the resultant injuries and changes in life that occur thereafter, in addition to the more pedestrian stuff like car crashes. But it was my great pleasure to kind of restore function. But I saw a huge need in this small field of the care of the amputee or person with limb loss, because there was so much more that we could do that I felt that we hadn't capitalized on. So I reached what you may not know is the University of Utah has a long history of brain machine interface work
Hmm.
going back to the mid 90s. So they're the first to establish a silicon-based technology that is implanted into the brain in the cortical structures, which are the kind of the surface level computational structures of the brain. And with that, they're able to extract motor control signals and to send sensory information. And that was kind of the premise of some stuff in the early 2000s called BrainGate, accomplished at Harvard and Brown and some other universities. So what we want, I ambitiously sought out to kind of bridge between medicine and research how we can take some of these silicon-based emerging neurotech devices to real patient lives, and I'm still kind of involved in that quest. And I think um, that there are huge gains in the marriage of these two technologies. So I worked with the neural engineers, Greg Clark and Jake George at the University of Utah for many years on the DARPA-founded research study called Haptics, where we wanted to develop a very dexterous um, set of naturalistic functional mobility of the hand to basically on the same level of human performance, and then to restore sensory function so that touching a finger was touching a finger and we perceive it in the same exact way. So yeah, I'd like to extrapolate more on that as we talk, but it's been a very fulfilling work, and I think that I didn't so much as find it as it's been waiting for us there collectively,
Wow.
kind of as the next step in advancing these technologies.
Well, congratulations on being named the Chief Medical Officer of BIOS. What was it about BIOS that made you go, yeah, that's where I want to be?
So BIOS is a great group of people. You'll find that in every startup, it's really typified by the people that had built it, have dreamed it, that are achieving it. And so in BIOS, we have basically the best of both worlds. We have people that are very familiar with, government and navigating funding opportunities, and that have launched successful businesses with silicon carbide manufacturing, and they've achieved kind of international level prominence in both like economies in those efficiencies. And so, they were looking for something that was life affirming, and trying to, they saw that their skills overlapped with some of the skills that we didn't have as a research team, as a research and clinical team. And so we married the two. And so, really we owe a huge debt of gratitude to Tim and Josh Miller, who, are a set of brothers that put this together, then Wendy Huang, who has really capitalized on this. And the chief scientific officer is Jake George, who has been recognized in a number of forums, such as the Forbes 30 Under 30, and has had a number of grants from NIH and NSF to, that are really unprecedented at his career, at his stage of his career.
Yeah, that's amazing. And I know that BIOS is working with some big names. From your perspective, what's some of the most exciting things happening now with those collaborations?
So, like I said earlier, right? It like there are, to me, this is the next intuitive development of this technology, where we can marry um, patient need to technological capability, and to accomplish that at a national scale, and to set the tone for broad adoption geographically, so that every American that has an accident and loses a limb can then acquire, a human level artificial limb. We need big partners to work with. Um, you know, Not to be excessively self-congratulatory, but this lab, born out of the University of Utah, is one of three labs in the United States, or
Wow.
three labs in the world.
Wow.
One in Switzerland, one in Ohio, and then us, who are kind of the most adept at restoring nerve and hand control to an artificial or robotic hand. So we trying to establish these partnerships so that there is no limit to where these technologies can be deployed. So what's interesting about like hardware and software design, once you do it once, right, you can ship it anywhere, especially hard with software, you could just download it, right? But the problem with the distribution of medicine, they often say that medical interventions or surgical interventions lag 20 years behind state of art.
Hmm.
And it's because it's so regionally distributed, and because the pathway to train a surgeon is long, or train any physician is long. So there's kind of a gap between what is trained and state of art, versus what's readily available in one's community. Plus, if you're injured in a rural area, how do you
Hmm.
know? How does a person know
Yeah.
to go to a regional center of expertise?
Yeah. Wow.
So that's why we're looking for these great partners. And to speak to it, University of Utah, like I talked to you about, has a huge pedigree in this domain. They also have the Craig H. Nielsen Rehabilitation Hospital, which which we built from the ground up to leverage needs of the patient, with adaptive controls in the room that work at their level, that has a fabrication lab in the basement, that has a virtual reality theater to kind of help with pain management and kind of imagining situations. So it's an amazing place. Craig Hospital has been a decades long leader in brain injury and rehabilitation. People come from all over the world to go there to learn how to be the best version of themselves. And
Hmm.
lastly, the Mayo Clinic. The Mayo Clinic is an internationally recognized center for experts in pretty much every domain, and they do a great job involving different subspecialties of medicine and integrating them early in a patient's care, so that the plan is cohesive, consistent, and easily executed. So we find um, we hope to build a fruitful partner with each of these, so that we can deliver the state of the art in each market, or at least have kind of fingers that spread out through the geography of the United States. And then from there, it's no question that the international deployment of these ideas will happen.
That's excellent. I read something. I'm going to read it off of here though, because you talked about BIOS using a three-pillar approach. And if I was going to go into that three-pillar approach, I'm going to butcher it. So I won't do that. But I'd love for you to explain it to people what that three-pillar approach is and what it really means for someone living with limb loss.
I just like to set the stage a little bit here with
Sure,
this.
please.
So I had talked about uh, that this is almost a foregone conclusion, right? Like there's no you find this all the time, right? Where we're on the edge of a technological breakthrough. Um, whether it's true about the discovery of calculus or if it's true about uh, television, there are all these multiple inventors that sit right on the cusp, right? And then there's kind of like a critical mass of technological competence that then pushes us over to get to a new transformational technology. And we are at that apex, and we need to capitalize on it just by virtue of the sheer kind of moral requirement of restoring people back to their best selves. And that's not even talking about expanding the functional envelope beyond what has been considered human performance to date, right? I think we can talk about that later, but it's fascinating, right? Not just restoration, but transcending it. It's almost a transhumanist bent. Um, but the three pillars that you referenced in terms of advanced materials, you know, um, the the nerves are small, right? Nerves are smaller than a human hair on average that travel down the arm. And their cell body, where they originate, starts in the spinal cord for motor control and goes all the way down to the tip of your finger, which, if you have to think about energetics and all kinds of stuff, and preservation of that through all the movement that we do, um, they're incredibly delicate structures and they're tiny. And each one is responsible for either, tactile sensation, touch, proprioception, where is your joint, you can tell with your eyes closed, or pain, right? That tells you to localize that area to remove the offending stimulus. Um, so it requires now our micro machining fabrication using, etching, chemical etching, machine etching, micro machine fabrication, and UV lithography allows us to get small enough on a scale
Wow.
to match the nerves in terms of um, spatial accuracy. And so, being able to communicate touch versus pain is hard to do. You have to be spatially selective. You have to go right to the nerve of interest. You have to stimulate it in the right frequency, which is a frequency coded chain.
Wow.
Um, and and you have to do it in a time frame that's relevant to the patient. So you touch it, you want to feel it then, right? You don't want to wait 30 milliseconds and feel like there's a bizarre shadow delay. Um, so we need advanced material fabrication, and that's why
Wow.
when Tim and Josh Miller approached the University of Utah group about this marriage and this collaboration as a neurotech startup, we were wildly enthused because they were bringing a skill set to us and an established track record that we needed, that we desperately needed. So advanced materials right here, and we're seeing this, day over day, day in day out with advances in this domain with shrinking, the ability to create micro machines at a smaller scale. Neurophysiology, it's we're learning the encoding patterns of nerves. I said that they were frequency encoded. That's kind of interesting because most of what we expect, like I'm listening to these headphones right now, these are voltage encoded, right? So usually, you turn up the voltage and it drives a speaker that then creates a bigger movement of the diaphragm that then allows us to hear, right, at a greater volume. So that's amplitude encoded. Nerves are funny. Nerves are all frequency encoded. And there's an opening envelope um, pattern in which is naturalistic for one type of nerve, right? It's kind of like the language that one kind of nerve talks, like tactile sensation or vibration or deep pressure. Those are all different. The touch that we have just on the tips of the hairs to say notice like a bug or a twig or something, those are all different sensations. So we in the last 20 years we've learned how to speak to each nerve, and that's even to the pain nerves. We
Wow.
can inhibit the pain nerves with this great spatial selectivity and turn and selectively turn off the pain signals, which is a huge breakthrough and one that we hope to capitalize on in the future. And then machine learning. This right? If there was a theme of 2025, is it machine learning uh, reduces the complexity for patients so that they don't have to think of turning the knobs and the switches historically because they have to control 10 things at once, like 10 different movements. We call it a degree of freedom. And you can think of it like an Xbox controller, right? Moving up is one degree of freedom, moving to the left is one degree of freedom, a button is one degree of freedom, but they convey different things. Uh, it's virtually impossible to have everybody that is missing a limb or missing a part of their body become like adept at using three Xbox controllers at the same time, right? Which is what it is. It's that degree of kind of dexterous control is required. So so when we do our training algorithms, we have videos that people just mimic, right? In real time, and then eventually our algorithms, which leverage some of the most advanced neural networks to date, um, encode the motor control signals right from the nerves themselves and right from the EMGs themselves. And EMGs are an implanted kind of a way to discern the electrical activity of the muscles. But um, but basically, instead of doing all the hard work of learning a new interface, these these machine learning algorithms, which are novel, and you're seeing them blow up in the LLM space, and you're seeing them blow up, you know, um, everywhere, self-driving to so just they're omnipresent. But but we don't have to teach a patient. We don't have to train them. All they have to do is imagine moving their fingers in a stereotyped way, like the video shows, and then within 5 minutes, they have complete control of their hand, right?
Ah,
And so
wow.
it's a very naturalistic way to engage, and the algorithm gets better and better as it learns you, just like voice recognition does with Siri or a similar competitor. And we know that that's a floor condition, right? We know that the algorithm that our capabilities now are nearing human performance, and they're only going to get better from here as we iterate on software and hardware development. And so we think that we could not miss out on this opportunity to improve patients' lives and restore them back to normal function.
Wow. I mean, it's really amazing how far things have gone. I pointed out some of my archaic prosthetics in the back there a little earlier. I have a question because when I interview people on the podcast and let's say they have limb loss later in life or during their life, they have the phantom pain, as most of us are going to be listening to know all about it. Me, myself, as a congenital, I don't even know what it's like to feel an index finger on my right side. And you
Yeah.
had mentioned congenitals possibly. So how does that all play in? Because I'm trying to picture this, like even for myself, if I was going to be someone that could use this type of technology.
Oh, that's the coolest question. And we think that in your brain, so the brain, as you know, has bumps and lumps and um, that look to us just like kind of a random shape, you know? But what's been discovered in neuroanatomy over the hundreds of, the 100 years since Phineas Gage and kind of other patients that have taught us about the brain is that there is a similar map that is preserved between you, me, and the rest of Homo sapiens, where it's called the homunculus, the little man in Greek. And there are areas dedicated to the thumb, the index finger, kind of in this broad section here. That you probably have that are purpose driven to control a hand, although it's absent, anatomically. And so you're pre-wired, you're pre-configured for that. And um, and those control areas are preserved in people with congenital limb absence. And um, so you can either extract the information here through a brain machine interface, right? And demonstrate that. Or, as the naturalistic pathways come down through the brainstem, the spinal cord, and through the motor control nerves of the arm, you can extract the signal anywhere along there because the signal should be the same. Um, so, with that, you could experience kind of a whole new perception, which
Yeah.
is cool, right? Like you don't come across a lot of like new extensions of the human body. and you can port instead of using, an artificial hand. You could do anything. You could drive your car theoretically. You could navigate, 10 different commands and control pathways on your computer in real time, right? It could be a VR interface. And that's something that we hope to do, right? Where we extend the envelope of human performance beyond just restoration of hand function.
Wow. Yeah, that would be definitely interesting to feel what it's like having an index finger on my right side. That would be interesting. So please keep going. I want to know what that's like. Hopefully it'll
You
happen in my
know,
lifetime.
to speak to that real quick, we did
Yeah.
have a patient, that had lost their hand 20 years ago. And then he came in, and this is when we were experimenting with these frequency encoded signals on when to touch the index finger and how to touch it. And so we'll share it with you. We'll send it over to you, the video. But essentially, he's touching a virtual door and he touches it and he has a gasp that's audible. And then he says, "Oh my God, wow, that was so cool. I haven't felt anything like that in 20 years."
Wow.
So that epiphany is what we aim for, because we want to just give back. We want to give back what people expect to have.
Well, this is why I'm excited about BIOS, and I'm so honored to have you on the podcast because this is awesome stuff, to say the least. You have just launched something called registries. I know it's for patients and caregivers and even healthcare providers. Why was that important, and what are registries within BIOS?
So I mean, what we need to do is we're trying to build a team and a framework which we can deploy this technology. So it's clear based on Star Wars that we know what the end goal is, right? To restore human function, just like Luke Skywalker after he lost his arm to the lightsaber. Uh, we need to make that a cultural imperative for the United States, and to help everybody, bring everybody forward into a shared vision of um, of restoring hand function. So to that end, we need to know who's affected, how they're affected, where they live, how we can help them. And there's a lot of complexities in those details, and we're working with kind of established players that have um, federally um, federally approved registries for gathering and maintaining databases with very sensitive data. And so we know that so much of this hinges on communicating what we have to people that have a need but don't know they have a need, or they don't know that we have a technology that meets their need. So I think that um, there's a lot of uh, public and private cooperations that need to happen still. So we're building out a registry as a way to kind of communicate with one another through all digital platforms, word of mouth, and patient support groups, to make sure that we share this information. We could use the example of a knee replacement, right? It's now common knowledge that those exist, or a pacemaker that regulates the beating of the heart.
Wow.
But that wasn't common knowledge. That wasn't the shared body of human knowledge that people had access to before those technologies came to fruition. And we're looking to kind of help people identify solutions for their shared need, and that's what the registries exist for. But we are very, just so you know, respecting the privacy and autonomy of people that self-identify or want to be involved in these things, so that there is no data sharing and there is no breach of patient privacy. And I'd like to come back to that later, about the importance of data autonomy and privacy in this respect.
Well, boy, I wouldn't mind talking about it now because you were talking about it before we actually hit record, and I was like fascinated by that whole area. So if you want to go into it now, I'd love listeners to hear this.
Yeah, sure. Let's just imagine. Let's do a thought experiment, if you will. Okay. Um, for a brain-machine interface, the cortical structures, so the computational surface of the brain, sits on the greatest surface area of the brain on the outside. It's what separates us from lower order primates, and it allows us to accomplish great things. Because you can plug into that through a brain-machine interface, you can extract information about either how you might be wanting to move your body, about how you might reflect on a different topic, or about your internal voice, your internal monologue. And those things can all be extracted, right? Theoretically. Your emotions sit deeper in your brain, but you could probably extract through tone and the kind of other metrics what you might how you might feel about a feeling. So just recently in a paper in Nature, they showed the ability to extract the internal monologue through brain machine interfaces, uh, which on one hand, for people with ALS and for stroke who have expressive aphasia, the inability to speak or construct language, or the inability to move the muscles in the case of ALS, they have all that ability to craft a great response. They just can't execute it. Those are great technology. Those are revolutionary. However, that's in the hands of a beneficent person, right? That wishes you no malign intent. If if we imagine a different scenario, right, in which somebody wants to involuntarily access your thoughts or access your dreams or access how your feelings about a particular subject, that's I think that's an inviolate uh incursion on somebody's privacy. And so there are no existing laws right now, as far as I know of, that enshrine the domain, the human thought, cognition, feeling, emotion, you know uh uh in the human head as it relates to brain machine interfaces. So I feel like that's a very protected space, and we need better data and privacy laws to protect individuals, just like we do with genetics, because we in the future, of course, we're going to know more to how to access and manipulate the information. We don't want to give away basic information now that may put us in jeopardy later from a hostile um, reading of the law from, say, an insurer or a payer to
Hmm.
kind of preclude us. Say if they pick
Yeah.
up traces of Alzheimer's or traces of, early cognitive aging, God forbid, and then say, well, by our own algorithm, we've determined that you're not a candidate for this treatment because we saw this 15 years ago. You know, I
Hmm.
mean, I'm just imagining kind of sci-fi realities, but the truth is, it's not that far.
Yeah.
It's not that far anymore. And we need data, and privacy agreements just like HIPAA, that are built up to protect individuals that have brain-computer interfaces, so that their own thoughts remain their own thoughts, and then that they're not widely published to people. One of the benefits and of nerve interface like BIOS is that we implant a nerve interface in the median and ulnar nerves, which you can think of them as like long USB extensions out from the CPU, and we can get the exact same information we want there for motor control and for sensory control and for pain relief easily. And we don't have to mess with the intricacies of thought, perception, one's perception of self, and also, if there's an infection on the end of a residual limb, it's inconsequential almost because we can treat it with standard antibiotics. That's a soft tissue infection. Whereas with the brain, it's a privileged space. The immune system does not enter there readily. And we want to keep inflammation there low, and we want to reduce the chance of infection, right? Because you only have one brain. And once you lose those cortical structures, we are not salamanders. There's no getting them back. So, I really think these peripheral nerve interventions are the way to go, and they're a way to extend human performance.
I want to ask you a question. It's a question that I ask a lot of listeners, or a lot of guests, and it has to do with, what keeps you going? Because I know this is not easy what you're doing, a lot of long hours and things like that. But the thing is, when I listen to you and how you speak and everything you're speaking about, you speak with passion about what you're doing. But what keeps you going? What keeps you going to keep moving forward and keep trying to help people?
Well, I mean, it's not complex. It's knowing people. It's knowing people and having a moral responsibility to push the ball forward. Um, and I think that I'll tell you a few stories, okay?
Yeah.
One of whom is a patient that I know and that we've showcased well in the past. He is a former Army veteran, Um, he uh, was involved in an injury during shortly after basic training, where he injured his hand and developed a kind of pain phenomenon called complex regional pain, where essentially all the nerve endings get miswired, and tactile sensation, which would be normal touch or cold or feeling some wind across your skin, just translates into pain. And it translates into pain, and it causes, changes in how the hand, the skin, the bone, the soft tissue of the hand, and basically renders the hand non-functional. So this is a super fit guy from Louisiana with the most charming, outgoing personality you could imagine. And he ended up working as a bodyguard, kind of leveraging some of his military training. He worked in the for multiple law enforcement agencies, but he found his hand was really in his way. So he approached us at the VA and asked, I've read about, your accomplishments with these nerve interfaces, and I'd like to be a part of it. And we we screened him very thoughtfully with psychologists and everybody else, and recognized that, he'd be an ideal candidate, that this hand was only an impediment to him. And, he had to wear it in a sling at all times, and it was cramped. And we removed the offending structures and the remending the injured nerves at the end, with our surgeon, Douglas Hutchinson. And then shortly after that, at the same time, we implanted the electrodes to be able to control a robotic hand and to sense touch. It was an hour and a half long surgery, but it essentially gave him a new way to use a hand, right? It's almost a hand replacement. Um, a digital hand replacement. And then afterward, I got to know him over the next years, and he became, very adept at using, every power tool known to man to, to fix up his house, to feed his dog. And I knew that this was going to be a successful technology when, we're sitting at his house, and his dog was kind of jumping up asking for stuff, and he just reached down with his artificial limb, petted his dog, and kind of manipulated threw a ball over,
Oh,
quickly, easily, and without thought.
wow.
Which, for those that have used the prosthetic before, with like a hook that is essentially Civil War ported technology, very functional, very robust, very durable, but it's still just one degree of freedom, or one way of moving things that requires a ton of like planning. It's like, how do you live your life with a set of chopsticks? You know what I mean?
Oh, I do.
Yeah,
I do know.
I know you do. No, and it's effortful. So much so you're gonna be like, well, you look, if I'm gonna pick up that pencil, or if I'm gonna like put in that AirPod, I'm going to reach over with my intact hand and put it in. There's no way you can do that, with metal hooks.
Oh,
Another patient I had, um, an amazing patient, right? She was a surgeon, and ended up injuring herself, losing both arms. And she approached me when she had a 2-year old. Um, and she wasn't lamenting about her inability to return to the operating theater. She was lamenting that she couldn't change her daughter's diapers without pinching her skin using conventional metal hooks. Which to me, I mean, at the time I had a 2-year old myself, and knowing the complexities and how squirmy they get, and what unexpected things you might find, it sounded impossible to do. And so, and we brought her over to the lab, showed her the ability kind of on some of our early prototypes of how dexterously she can move her hand. And within 10 minutes, she was controlling a hand, a robotic hand that we had on the table there, with 100% precision. And so, there's stories like this. Like, does society need a well-trained surgeon in whom we've already invested, 15 years of training, to return to the operating theater? Yes, absolutely we
wow.
do. Could a surgeon control a Da Vinci robot, which is, a very sophisticated microvascular, and it's a surgical robot, with extensions through nerve interfaces? Yes, they easily could. Um, and more importantly, can she live a life in a meaningful way, right? Where she could do everything and never ask for help? Because nobody should ask for help for anything, and we should build a world in which nobody needs to ask for help.
Wow. Very exciting. And let's talk about exciting. What are you looking forward to in the future with BIOS over the next 5 to 10 years that you were allowed to discuss and people may want to hear about?
So, so what we hope to achieve in the next year, in the next few years, is to complete the multi-site trials that will provide the strongest data set to support to uncon to just to support broad adoption of this technology. I mean, I think this is a shared belief that we want as as a society. We have the tools to accomplish that. We're building out the study that shows that. Um, like we talked about with our collaboration partners before, uh, um, we want to train surgeons. We want to teach rehabilitation professionals like hand therapists, occupational therapists, um, and physical medicine rehabilitation doctors, as well as primary care doctors, kind of what's available out there. What and prosthetists, the people that fabricate artificial limbs. We need to teach them kind of what's available, and we need to lead the way. And so we're going to do that by showing that we can provide superior function, we can mitigate depression, we can mitigate pain, and that we can do it safely without complication of infection or or any other risk. And so that's what we hope to accomplish. Um, Eventually, we will make this device completely wireless, and and then after that, we look to kind of make it more robust so that it can be implanted, say, in the lower extremities for people missing parts of their legs. So for every one person that's missing part of their arm, 10 people are missing part of their legs
Yeah.
because of the nature of diabetes or vascular disease. It affects the longest parts of our bodies first, right? The areas that are the furthest away from our hearts. And um, but those areas take a beating. So for the hand, there's a different, check this out. This is really cool. For the hand, there's a different use case, right? You want dexterous movement. You have to control a lot of things with high degrees of precision and accuracy, but it's not mission critical, right? Like if you drop a pen, or gosh, if you drop your fork, at a fancy restaurant, it's embarrassing, but we'll probably figure it out. Um, but when walking, right? If a leg, if your foot missteps and or your knee doesn't extend, right? It will set you up for a possibly catastrophic fall. And in whom, in the elderly population, that could result in injury to the head or to the hip, which would be, very consequential to their function. So it's a different use case entirely. So, we hope to extend in that direction. And then just kind of speaking to the ability of a technology just like this, it's one side of the bridge that is the cure to paralysis, right? If we imagine a brain machine interface being able to extract information up here, um, there is no other way to um, restore that function in the arm unless you have a nerve interface. Um, and so we know the future of movement for spinal cord injury is coming. We just need to build the tools for it. And this is one half of the bridge. The other half of the bridge will probably be brain computer interfaces.
I just want to remind everyone too where you can be found. You can be found at Biologic Input Output Systems.com. So if anyone wants to learn more, go to that website. There's so much information on there. We were talking earlier about the prosthetic that I used to wear, and I know that people like me, they kind of go in and out of them sometimes because there's an abandonment from using a prosthetic like a hook, and it's in the background if people are watching this video. Why do people stop using prosthetics like the one I have?
You bring up a great point there. Um, Everybody hates having their car in the shop. Clear, right? But having your hand break down when you had plans for your hand, when you had things to do, is is a huge disappointment, right? At first, you're like, you're still loyal to, to the hand. But after it happens the fourth or fifth time, right, you say, what is wrong with this lemon? And that is the case with, a lot of prosthetic hands where they break down and require, shipping off to the manufacturer for repair. And, so, we're looking to reduce the amount of complexity there is. And then also, the time cost of using kind of some of the more simpler hands, right? Like where you have to plan your activity and how you're going to use it before you actually do the activity of interest. If like say it's a mug on a coffee cup, you have to think about how to position your body, how to rotate your shoulder, how to extend your arm, how to then twist your wrist when normally we do all those things kind of in a fluid manner. We look at an object and we know how to grab it, the hand conformation, the contact pressure, all that. Um, and so, we're trying to mimic this using our sophisticated algorithms to kind of build in ways in which the hand can move dexterously to grab objects so that you don't have to add any extra computational oversight from extra attention, time, and cognition. So, too many people with upper limb prosthetics abandon them, and I think that is a consensus-driven opinion of of which is to say the technology just isn't good enough. And so, we're trying to meet the moment there. And just like we talked about with the three pillar approach, we're there. The technology is there. The patient need is there. We have the right team. We're one of the world's leading groups in this domain. And I think it's absolutely credible. We just need to bring it to the world.
Well, my story is exactly what you talked about. My prosthetic broke, and I was just like, and at the time, my parents were providing me with a prosthetic, and they asked me if I wanted to get it replaced. And I think
Yeah.
at that point in my life, I was kind of on and off with them for a multitude of reasons. Most of them you've already stated. It's just not as dexterous as my hand. And I just said, no, I think I'm good. And I haven't worn one since then. But boy, the promise of feeling an index finger on my right side, I'm, I'm so intrigued by that. Chris, I can't thank you enough for explaining everything, the great things BIOS is doing, and for taking the time to be on. You have an open invitation anytime you want to come back on, because what you're doing is not only fascinating, but it's so important. It's going to help so many people. So thank you so much.
Likewise, you have an open invitation to our lab to come test drive it, okay?
Oh, I
Anytime.
love that. Thank you. Well, that's the end of today's podcast. Thank you, Chris Duncan from BIOS, for being on. What an exciting podcast. By the way, if you want to see what they're doing over there, if you want to be part of the research that BIOS is doing, reach out to them. Their email address, info@bios.works. They'd love to hear from you. And by the way, you want to be on this podcast? I'd love to hear from you as well. Reach out to me on we're not stumped.com.